Welcome all of you to this live program about orthopedic principles. Today, our guest of honor is Dr. Achilleas Boutsiadis from Athens, Greece. Achilleas graduated from medical school in 2002, followed by orthopedic residency at the 424 General Military Hospital at Thessaloniki. Later, he joined as captain at the Hellenic Armed Forces Medical Corps and was a resident in orthopedics at the Hospital Papanikolaou in Thessaloniki, Greece. In 2012, he was appointed as consultant orthopedics at the 424 General Military Hospital of Thessaloniki, Greece. And subsequently, in September 2015, he was awarded a PhD for his thesis on basic science of rotator cuff pathology. And later, Dr. Boutsiadis completed a fellowship in Clinique de Cetris, Grenoble, France, and shoulder and knee surgery. If you notice, Dr. Boutsiadis has delivered a lecture on our channel in the past. It's already reached a huge audience, and today it's my great honor to bring back Dr. Achilleas Boutsiadis for this wonderful live program. Over to you, Achilleas.
So thank you again, Professor Hit, for the invitation. And today a little bit different. Let's go to the knee and let's go to a topic that is very debated nowadays among our community. So techniques and indication to make not only an ACL reconstruction, but also to make an ALL reconstruction at the same time. In 1980s, we had the revolution and we had the ACL reconstruction using the BTB tendon. And this is the Lyon knee school. And they described very, very good clinical results. However, it was a little bit technically demanding. And in the 90s comes the fashion of the hamstring tendon autograft. And the ACL reconstruction became very famous and very, very easy among orthopedic surgeons. And in 2000, we passed also from the single bundle to the double bundle. And also the materials, the development of the materials helped us a lot in this progression. From the staples, we went to the screws or to the pins, and then they came the button. Initially the rigid buttons, and then the adjustable buttons. However, we had long-term failure of the ACL ligament reconstruction. And the ACL graft failure, it can be anatomical, or we can have a clinical failure. And now we can see we have percentages that starts from 3.2%, but can arrive about 27% of a failure of our ACL. And this is a very good article that says that probably an ACL reconstruction, they compared two groups, one group that was not operated and one other group that was operated with an ACL reconstruction. And yes, these had us a very less need for surgery compared with a non-operative, and especially for a meniscal surgery. And we can compare that we don't need any additional surgery for operating these patients, about 14%. However, what is very important that the pivot shift test, it remains positive, about in 25% of these patients compared with the 50% of the non-operative patients. However, this did not reach statistical significance, and we have in about 1/4 of our operated patients with a positive pivot shift test post-operatively. So 2013 come up Stephen Klaes with this very good study and with this idea. We have the anterolateral ligament of the knee that we have lost it during the last years. This is a new anatomical element that comes up and says that the second fracture that we're seeing so many years right there is the insertion of the anterolateral ligament of the knee at the site of the tibia. Since then, everybody knows that the Star Wars came up worldwide. And we have Stephen Klaes and Bernard-Henri Cotet from France. And we have also from the English part and the American part that says that probably is the new emperor's clothes and nothing covers. This is not something new. Does this really exist? We have many studies that yes, really it 100% exists. And we have some studies that 0%, it doesn't exist. We have anatomical evidence that in anatomical study, we have a lateral ligament that is found. And some also authors says that it's a capsulo-osseous layer of the iliotibial bud, and the middle third capsular ligament is construct right there. However, I have to admit that also I have performed some anatomical studies. This is not all published yet, but yes, there is something there, and it resembles the ALL, the anterolateral ligament. The radiographic evidence to find it is really, really difficult, and nobody can be sure that we can find the ALL, even the normal or the torn one. However, we have to admit in the MRI that is a femoral part of the ALL, a tibial part of the ALL, and also there is a connection between the ALL and the lateral meniscus. And it's very difficult to find. Here we can see that it's probably a torn ALL from the femoral side, but it's very difficult, and it also depends from the way of the MRI it's done. Arthroscopic evidence, some authors also try to find it arthroscopically, and yes, some they reach to find it. We have also to say that we have all the other important lateral structures, that is the proximal Kaplan fibers, the distal Kaplan fibers, that they offer also they're very important for the rotational stability of the knee. And what is the importance of probably the ALL? Is not to over-constrain, but to prevent excessive internal rotation. And what about biomechanics? Where is the insertion of the tibial side and of the femoral side? Stephen Kleiss and Elito says that just in front of the epicondyle, the lateral epicondyle. Dodd says that just posterior to epicondyle. Some others says that the level of the epicondyle. Everybody says it's just behind of the ZD tubercle at the tibial side. However, the ALL, it seems not to be an isometric structure, and it seems to be tension between 0 and 20 degrees, and really, if you go to flexion, seems to be not very, very tight. But do we really need this, and when? So this idea came up when we have performed a study. It was a different study to see what's happening if we use an adjustable button or a screw at the femoral side when we do an ACL reconstruction without an ALL. And we tried to compare these two materials. This was not a study for the ALL, and we just want to include it and to make two groups of patients very, very clear. Acute ACL tears we found clinically with the MRI and with the telos, and we didn't have any surgery delay above 6 months. And the exclusion criteria, meniscal lesions, cartilage lesions, revision cases, or that we had operation at the contralateral side. So we tried to make two groups of patients that was really, really unique only with an ACL tear. And we made the clinical assessment with the Lachman test and the pivot shift test. We measured the anterior laxity with the telos, and also we have also measured the IKDC objective score before the surgery and 2 years after, and the Tegner activity level scale, and also the COS score. And we, from 2013 and 2015, from 1,136 ACL reconstructions, we came up with two groups that finally consent 121 at the one group and 100 at the 51 at the other group. The 21 group was screw at the femoral side, screw at the tibial side, and the 151 button at the femoral side and screw at the tibial side. And preoperatively, these two groups were similar regarding the age, the sex, the delay, the Tegner activity level scale, the graft size, and the laxity. So we tried to make two equal groups. Even also the pivot shift test preoperatively was also approximately the same. What we found, that we had residual laxity 2 years post-operatively, 1.9 plus minus 2 millimeters post-operatively. And these two groups was a little bit significant, the comparison between these two groups. What we have to see that we have some cases with post-operative laxity that reaches about 8 millimeters, 7 millimeters post-operatively in cases that we didn't have any other structures damaged. What was really, really important is that we know if you have a post-op laxity above 3 millimeters, this is clinically relevant. This is not very good for the patient. And what we have found is that if you had a pivot shift test preoperatively 1, you have about 20% of probability to have post-op laxity above 3 millimeters. If you have a pre-op pivot shift test 2, you have about 50% of probability to have a post-op laxity above 3 millimeters. And if you have preoperatively a large pivot shift test of 3, you're about 90% to have residual laxity. This is very important. The pre-op pivot shift test seems to be very, very important for these patients. And also, the cutoff point of pre-op laxity also seems to be the 7 millimeters. So, two bad factors, 7 millimeters pre-op laxity and pivot shift test above 2, you are probably have not very good post-op result. And also the age was another factor. Very young patients seem to be bad post-op laxity. So this was published in American Journal of Sports Medicine, and we found that the patients with 6 millimeters preoperative laxity, pivot shift test above 2, and age below 20, they didn't have very good post-op laxity. So we came up with a minimal invasive combined anterior and anterolateral knee stabilization in these cases. This is a technique we have developed with Johan Barth and also Jean-Claude Panisset from Grenoble. What was our further indications? Revision cases, technical activity level scale above 5, BMI above 25, recurvatum knees, and delay above 12 months. Meniscal injuries, we have this study from Santi that says that if you do an anterolateral ligament in these patients, probably you protect the repair medial meniscus. And we think that they have right, because you lower the percentage to have positive pivot shift test after the operation. So you don't have torsional forces. The presence of a second fracture and also the presence of a lateral femoral node sign. This sign is an indirect sign that you have also a subluxation of your knee during the initial injury. So we have further also indications for an ACL, also an ALL reconstruction is probably an ACL primary repair. We also made another study, and we also wanted to compare if you have add an ALL or a BTB graft or a BTB graft with an extraarticular tenodesis using the fascia lata in cases that we have preoperative laxity above 8 millimeters. And what we have found that the ALL give us better results regarding the post-op laxity and also give us better results regarding the post-op pivot shift test. Also, the graft failures right now seems to be better. We don't know the long-term follow-up, but give us better results regarding also the anatomical graft failures. So the Lyon School described this, the Lemaire technique, and also the over-the-top technique continuously from outside of the knee, and also Philippe Colombe in 2012, I think, described also this technique that seems to be, he tried to make an ALL and anterolateral ligament at the same time. So let's see how we can perform this operation. Is this really, really difficult? And let's take a case. 32-year-old male, he had his right knee and he had a torsional injury 16 months ago. Immediately he had knee swelling, he had instability, great instability. We measured with the Rowley method 12 millimeters of difference and the pivot shift 3. And this is the MRI, torn ACL, and also edema at the lateral, if we see it more carefully, at the lateral side. However, he had a delay. And let's start the operation. We clean up a little bit the fat pad. And we see the torn ACL. This is a device. It's a device with a saver and an electrocautery device at the same time. And let's see, this is the lateral meniscus, seems to be okay. You see it? And then we go to the medial meniscus. But we see that he has started to have a tear of the medial meniscus. So we make, with a saver, we try to make a saver at the meniscus, and we put an all-inside meniscal suture device to suture the meniscus. Okay, we think that is good, and we stop with the suturing the meniscus. We believe very well to the biology, so we don't saving any remnant. And you see, this is a technique using for the subscuff, for the rotator cuff. We pass a suture through the remnant of the ACL, and we make a lasso loop. And then we clean up the femoral knots. And we preserved all our ACL. So right now, so at the femoral side, we use a guide that is an outside-in guide. And we place the guide intra-articularly at the insertion of the ACL, and we make all the tunnels from the outside. This is the guide, and and we make all the tunnel, all the reamers. And finally, it's a whole tunnel. It's not like the ACL. We make a full tunnel of the femoral side. And we see finally we can put our camera from outside inside the femoral tunnel. And this is the saver from the medial portal. We see the very good tunnel, and this is the tunnel from our medial portal. At the tibial side, we try also to put the guide at the center of the ACL, at the center of the ACL remnants. And also we make a tunnel, we make the samba technique, this is the samba dance of the ACL remnant, and we make a tunnel that is the same size as our ACL graft. We clean up. And we start with the 6 millimeters, and then we gradually increase the reamer. I don't make directly the final tunnel because I don't want to make any mistake, and also I don't want to burn the bone. So I start with the 6 millimeters, and then I go gradually to 8 or 9 in order to not to burn the bone. And this is the image. We have already performed our femoral tunnel and our tibial tunnel. And then let's go outside. This is our femoral tunnel, you see, and then we just behind the ZERD, we put our inserter at the tibial tunnel not to connect them. So we start from the medial side, and then we exit the pin at the lateral side, where is the insertion of the ALL at the tibia. And then we make a 4.5 millimeters, and then from the lateral side, not a full tunnel, but just at the level of the cortex, we make a tunnel that corresponds the diameter of our ALL. So we finished our tunnels. We have performed the femoral tunnel, we have performed the tibial tunnel for the ACL, and then we have also performed a tibial tunnel for our ALL. And this is our preparation of the graft. We put an adjustable button at the level of the tibia. We make a 4-strand plus the gracilis, a 5-strand graft for the ACL. And also the continuous of the gracilis, it is our ALL from the femoral side outside. Okay, so we perform a graft. Here it resembles that the graft we made the short grafts for our all inside techniques. And this is our final graft. You see, we have an ACL part with an adjustable button at the tibia side. We have only one traction suture here at the femoral side, and gracilis continues laterally, and this is an adjustable button for the tibia side for the ALL. It's a little bit demanding, the preparation of the graft, but if you do it 1 or 2 or 3 times, it's really, really easy. And which is the length of our ALL? We are measuring from the femoral side from the exit of femoral tunnel, also to our ALL at the insertion of the tibial side. And then we go up. We pass the graft behind our remnant, and you see we have measured here that the level of the 2 centimeters are inside the tibia. So we fix our graft at the femoral side with a screw, and it's the same diameter with a tunnel. And also at the tibial side with the adjustable button. So we fix initially the femoral side with a screw, and then it's fixed, and then we go to the tibia, and with the adjustable button, we take the tension. So it doesn't really matter the length of our ACL. Then we go laterally, and we pass our tendon, the graft, below the fascia lata. And then we pass it from the medial side. And then we fix the adjustable button of the ALL in full extension. Finally, what we are doing, we also tension the ACL, the remnant. We take the sutures of the remnant outside, and we overtension also our remnant. And you see, we have the remnant of the ACL that preserves its vascularity, and behind of it, we have the ALL, the graft of the ALL. This is the final image. But if we see it, we can see here that we have the ACL, and then we have the ALL that passes from outside of the joint, and then inserts the tibia, and it's tensioned with an adjustable button from the medial side of the tibia with the adjustable button. We have seen some cases with a second look arthroscopy, and this is our graft 1 year post-operatively. You see it, and we have passed also a root repair, and you see that the graft, the ACL graft, what we have preserved also the remnant. It seems to be a very good quality. And also, this is the MRI. I can make it, you see that we have a very good quality. It's black, our graft. We have a very good quality of our graft. So take-home messages. We have the lateral structures that there exist. Is this torn during the ACL tear, the ALL, or it's elongated and it doesn't function over the time in a deficient ACL knee? However, we know that it can protect our graft, and also it can protect our meniscal repair. We don't really know with the geometric point of fixation, but I have to admit with this technique, I didn't have any stiffness of the knee, or I didn't increase my complications. ALL, or lateral extra-articular tenodesis, they came up on our field, and we know sometimes, and we have the indications right now that we did it. We do something anatomic or non-anatomic. However, I don't know the real answer. However, I have to say that we have to keep a balance in our knee, and something that we put from the lateral side of the knee is something miraculous and give us extra rotational stability. So thank you for your attention.
Thank you, Achilles, for this wonderful presentation. Let's have a short Q&A. Achilles, interestingly, I have hosted Professor Hantes from Greece on Leme's procedure. And
yes, he
so
makes
now, yeah. So my question to you is, see, you have a good advantage of doing it arthroscopically, right? the ALL reconstruction compared
Mhm.
to a lemur which needs an open surgery, isn't it? So is there any, yeah, I can't see you, Achilles. I think your network has an issue. Achilles, are you online?
It's also an open, it has an open. Yes, I'm online. Is there a problem with the internet? It's
Yeah,
okay
I think
right now?
your internet is a bit it's not, I mean, it's not giving a smooth connection. Yeah, fine. Great. You can go ahead.
So with an ALL, it's something is also extra-articular. It's mini open. It's because I have small incisions. Okay, I don't need to make a large incision and to take the graft from the fascia lata. So right now that in cases that I have the hamstrings, I can use the hamstrings for both very easily and do not destroy, for example, the fascia lata. Right now I'm keeping the lemur for revisions that I don't have hamstrings. I don't want to harm the other leg, so I take the BTB and I make the tunnels of the BTB, and there's also the fascia lata, and I can take it and make the lemur. However, for the lemur, I'm not taking it. I don't pass it underneath the lateral collateral ligament. Okay, I fix it just behind or at the level of my femoral tunnel for the BTB, and I think it's very good. However, yes, it is open. If I have the hamstrings, why not? If they're there, I know right now to prepare my graft, and also I keep it, the fascia lata, also I keep it there, and the Kaplan fibers and everything, I keep it there, that I think also they're really important.
Yeah, thank you for that. And well, is there any other level 1 data that is available that compares an ALL versus a lemur? Is there enough data?
Right now, there's no very good data regarding you. So that they're very without any bias. You see, we have the school from Lyon that comes from Bernard Cotet, that is, he's in favor of the ALL and supports extremely very good results. And his studies are published in AGSM every year. However, Bernard Cotet makes something different, makes two tunnels at the tibial side for the ALL. Okay, for our technique is one tunnel at the tibial side, and we're on the adjustable buttons. So we live on adjustable buttons. It's a very good game. For the other side, for the lemur, we have from there are many studies that come from the past that we had good results. The problem is what happens in the long term if we over constrain the lateral compartment. We don't know it yet. We'll see in the future. But if you ask me if I do an ALL or LMR when I do also a repair of a lateral meniscus, yes, I do it. I don't know if biomechanical it's okay, but I think that I'm trying not to over constrain, but I'm trying only to give some rotational stability. So even if I have a lateral meniscus tear, chronic, yes, I do it. And I'm really happy right now.
Thank you, Achilles. Achilles, and also you are relying on the femoral side tunnel for the footprint of the ALL, right?
Yes.
So do you think you're right at the femoral footprint of the ALL, because it's almost indirect, right? So you're not sure where the ALL footprint is on the femoral side.
At the femoral side, I go just behind the epicondyle. So with with the outside in technique, right now I do not do any inside out. I always do outside in. So for the outside in, I put inside the joint where is the ACL, I believe, and outside the joint outside a little bit behind the epicondyle. So at the same time, I have the insertion of the ACL inside and the insertion of the ALL outside. I choose this, and this helps me a lot, and it's make more technically easy to make ACL and ALL. Because if you do a tunnel from inside outside, from a medial portal, then you have to open from the lateral side to make the ALL with a different tunnel, and this makes it extremely difficult. So with one tunnel, you're finished. You're just finished.
Thank you, Achilles. Achilles, I think that's all the questions that we have for this session. Thank you for this wonderful presentation and a great surgical technique.
Thank you again, and apologize for the internet. It's not my fault. Okay,
No worries.
I think that you like it, and I also would like to promote to adopt this technique. You really would be happy with this. Okay.
Of course. Thank you.
Thank
Bye-bye.
you.